Welcome to the Chamberlain University Mastermind session. My name is Dr. Danica Bowen, and I'm the Senior Director of Higher Education and Global Partnerships at Chamberlain University. This week, we are going to have a rich discussion of COVID-19 and the rollout of the vaccinations. With me today, I have three incredible panelists, Dr. Jill Price, Dr. Katie Kay, and Dr. Kristen Dickerson. Let me start with the introduction of Dr. Price. Dr. Jill Price is the Senior Director of Post-licensure Nursing Programs at Chamberlain University. Dr. Price has 28 years of experience in the nursing profession, including critical care, nursing research, consulting, academics, administration, along with strategic planning and development. Before joining Chamberlain, Dr. Price lived in the U.S. Virgin Islands for 17 years, working as a nurse manager, assistant director of nursing at the Juan Lewis Hospital, and Vice President of Virgin Islands Cardiac Center in St. Croix, U.S. Virgin Islands. Dr. Price worked collaboratively with the U.S. Virgin Islands government, including senators and USVI delegate to Congress, to secure federal tobacco funds to strategically plan and manage a $25 million cardiovascular center of excellence. Dr. Price received a Doctor of Philosophy degree in education with a nursing education specialty from Capella University. She earned a master's degree in nursing and a bachelor's of science in nursing from University of Phoenix, and an associate degree of science in nursing at the University of Kentucky's Jefferson Community College. Over the last 7 years, Dr. Price has lived in Kauai with her husband of 23 years and her 2 children. Next, I'd like to introduce Dr. Katie Kay. She is the Senior Director of National Academic Operations at Chamberlain University and is responsible for providing leadership to university-wide operational quality initiatives. She has 15 years of experience in the nursing profession, specializing in critical care, emergency medicine, healthcare systems operations, nursing administration, and academic operations. Prior to joining Chamberlain, Dr. Kay was an administrator at a large metropolitan hospital where she had oversight of day-to-day operations of 22 inpatient units. Primary areas of oversight included patient safety, throughput, accreditation, advocacy for nursing practice, and reattainment of magnet distinction. Dr. Kay is a member of the American Association of Critical Care Nurses, the American Nurses Association, and the National League of Nursing. She also serves as the Metro Health Foundation Board of Directors, where she's actively involved in the community health initiatives. Dr. Kay earned her doctorate of nursing practice from Chamberlain University, her master's degree in nursing science from Walden University, and her bachelor of science in nursing from University of Akron. And last but not least, I would like to introduce Dr. Kristen Dickerson. She is the statewide manager for health, wellness, and specialty programs for Ohio BMC. She's worked in both the private and the public sector at all levels of government and within hospitals. She's obtained a bachelor's in microbiology with an MPH and PhD in epidemiology, as well as being a registered nurse and a certified lab technician. In addition to working with biowarfare in the Army and serving in public health service, she's been a regional infectious disease epidemiologist, infection preventionist, quality improvement coordinator in the prison system in Ohio, and a program administrator for population health programs, in addition to being a visiting professor and subject matter expert at Chamberlain University School of Nursing. During the COVID-19 pandemic, she has developed continuing education for nursing staff, a contact tracing course for Chamberlain, and presented about safe practices for nurses. She's assisted in local health department efforts in disease investigation and vaccine planning for COVID-19. In addition to this, she is currently serving as the workstream manager for provider identification and enrollment under the Governor's Vaccine Preparedness Office in the state of Hawaii. So I'm very much looking forward to our discussion today. As you can see, we have 3 incredibly qualified panelists to have this discussion, and each are coming from a unique perspective as we dive in. So let me just go ahead and float the first question out there, and then we can jump into a discussion. So let's go a little bit around the table. Can you share where you live and then your role in the distribution of vaccines?
Great, thank you so much, Danica. I live on the island of Kauai in Hawaii, and although I'm an academician, my current role in vaccine distribution, when the COVID pandemic started, I felt like I needed to do something to help my fellow colleague nurses and help our small community island. So I joined the Kauai Medical Reserve Corps, and as being a part of that Reserve Corps, I've been able to participate in the vaccine distribution through the Department of Health. We started giving the Moderna vaccine the week of Christmas, and to date we've given almost 3,000 vaccines to our small community of 72,000 people.
Just wonderful, and it's great to hear how it's being distributed on Kauai. Kristen or Katie, what are your thoughts?
I live in Ohio, and I currently serve on the I currently serve under the Vaccine Preparedness Office with the governor and the adjutant general in Ohio. They've set up a specific office to ensure that the vaccine is distributed equitably. There's 12 different work streams. One is allocation, one's provider enrollment and education, one is POP-SEG. So there's a lot of different work streams that go together to make sure that the vaccine is distributed, allocated, and put in arms in an efficient manner. So there's a lot of meetings and a lot of thinking involved in trying to strategically decide where the vaccine goes, who gets it, and how the vaccine is supposed to roll out to communities.
Thanks. I'll go next. I'm in a little bit more of a unique position because I still have my part-time role at Metro Health Medical Center, where I get to see how the vaccine is being rolled out to frontline staff and caregivers, as well as how Chamberlain University is partnering with entities really all across the country in their rollout efforts. So whether it be state agencies or healthcare partners themselves, I've heard a lot of different ways and strategies on how the vaccine will be rolled out to healthcare providers themselves, as well as the members of our community.
Wonderful, and thank you for that. And I'm just going to dive in with one of the most common questions that I've heard. How do you know when it's your turn? I have a friend and neighbor who, and I'm going to say the word unfortunately, has made 100 phone calls to try and figure out when their turn is. And I'm guessing that it's clogging up the systems. Is there a good way to know when it is your turn to get the vaccine?
I could start. I think that it definitely depends on the state. Each state, they're following the CDC guidelines in terms of the tier systems and who gets it first. I mean, obviously it makes sense that healthcare workers need to get it first because they're there on the front lines taking care of everyone. And then, depending on the amount of vaccine that each state is getting also is a factor in who gets it first. So these tier systems, 1A, 1B, 1C, I'm sure everyone is hearing about those and reading, watching on their local news or reading in the paper, like where the state is within those tier systems, and then you can kind of follow who falls in line. But there is a concern about vaccine wastage, and so even though states are following the tier systems, they're now having to plan for, in the event that not everyone shows up for their appointment that day, because things happen, then and you've already have these doses ready to go, then some states, at least in Hawaii, they have a standby list on the island of Kauai. So we're able to call and reach out to those that are scheduled for the next day for an appointment and ask them if they want to come in that day, because we have extra vaccines that day. So that's how we can ensure that no vaccines are lost. But in Kauai, we are still on 1B, so in the tier system 1B, and that includes still some frontline healthcare providers. They're actually starting to get their second dose right now, and in addition to police department, fire, essential personnel, and we've made it through even our teachers. But again, we're a small island, so it's a little bit more manageable. And we don't, and then our hospital systems, so the Department of Health is one site that's giving the vaccines to the community members. And then the hospital systems have also started doing max vaccination for people over 75, which also fall in the 1B category. We anticipate that we'll get through 1C, which is, the final category, if you will, probably, throughout April, May, but again, depending on how many vaccines that we get sent to the state.
So just a quick follow-up, Jill. What does it look like? So are people making an appointment and then they go and see their primary care, or does it look like the row of cars, people coming through? What's the scene over there in Kauai?
Yeah, so in Kauai, we don't have that yet, roll of cars, but we do have lines of people. And right now, it's all through social media and TV, the news channel as to who's being vaccinated next, and where you need to go to sign up for an appointment. Everyone does have to complete an appointment, schedule an appointment rather, because they have to complete some technology, some work in the computer. Basically, it's called the VAMS system, or Vaccine Access Management System. And so that's where the CDC is tracking how the vaccines, where they're being given and when they're being given and to whom. And so you get a registration link. So once it's your time and you go to the Department of Health website, or we actually have what's called a Kauai Emergency Management Authority, or KEMA website. And on there, it has all the information about COVID-19 vaccination, who's next, where you can sign up and go. And then you just start signing up for an appointment. And, it's once the appointments are full, then, that accounts for the amount of vaccines that we got for that week. And we're just doing this on a weekly basis. But on Tuesday, we gave 510 vaccines in about 4 hours through the Department of Health. And a lot of those individuals were repeats, getting their second dose from the beginning. A lot of primary care providers and their staff. So we don't have primary care providers giving it yet in their office, but I know that's soon to come. And then our transportation folks, so TSA and janitors and different things that work in education, because we did our teachers last week. But the line was quite long to serve 510 people within 4 hours. You can imagine the appointments are like 15-minute increments. And although it takes only a second to give the vaccine, it takes about 15 minutes to do all the paperwork, and then you have to observe afterwards. So we're observing patients for 15 minutes after they get their vaccination, and if they don't have any previous allergies or adverse responses to any vaccines, the 15-minute mark. But if they do, and we end up giving it, they have to observe for 30 minutes. So it can take up to an hour, even coming for your 15-minute slot appointment.
Very interesting. Is it a similar scene in Ohio?
Not really. We have 88 counties, and each county kind of comes up with their own plan on how they want to get the vaccines into people's arms. The governor and ODH and the director of health here, they work as a team, and they take guidance from population segmentation workstream, and they take the guidance from the CDC as well as ACIP, because before every phase comes out, ACIP will give guidelines on who they feel needs to be within that phase to get vaccinated. Yeah. So they take this information, and with our approach to phase 1B, they broke it down. So this week they're in 80 and above. Next week it's 75 and above, and then till we get to 65. And they will be starting to vaccinate the teachers along with these individuals starting in February. And they've also, within the phase 1B category, there are people with that make them high risk. So they've decided as of next week, it will be those that have developmental disability and one of these high risk high risk individuals. But the following week, it'll just be those that have that high risk, that fall into that high risk category. And that does follow exactly with what the ACIP had said. But again, once we decide who needs to be vaccinated at the state level, but then the states take it from there and decide how the counties take it from there and decide how they want to approach. Sometimes you get health departments and hospitals working together. Sometimes they're working on different segments of that population.
Interesting. Is that what you're seeing, Katie, in the hospitals as well?
Well, I think Jill and Kristen said it really perfectly. It's a lot of variance between how different states and counties are working to operationalize administering the vaccine. Well, we have a good tiered system in place of who should get it next, and that may or may not be that different across the board. It's how we're getting that vaccine to different individuals or the populations that we serve, depending on all the different external factors that might be in place or that an individual might encounter living or residing in the state or county that they do. Even just looking at Ohio, very geographically different across the board. So what may work in Cuyahoga County to administer the vaccine to vast populations is not going to be the same as some of our other more rural counties in Ohio.
So during this process, the individual comes, they sit down for their vaccination. What types of questions are you hearing from these individuals? Are they concerned? Are they nervous, excited? What are they wondering about?
So when I'll go. When I started first giving the vaccine before Christmas, everyone was so excited that they were taking it as if it was their Christmas present that they got early. And again, these were healthcare providers, frontline essential workers that were in category actually 1A. That's how we started it. But there were some individuals, interestingly, that their job is requiring it. So for example, here locally, the police department and the fire department, they're requiring all their members to get the vaccine. And, we all know that there are some anti-vaxxers, and that's fine, those that don't want to get it. And so some of those individuals that were a little on the fence, but they had to get it because they need to have it to keep their job, they were a little bit more nervous. And so, I was able to calm them down and relate to them. So, one of the key things that I have been saying to the clients as I give them is that, I have received it. So I think that helps to, well, if you're a healthcare worker getting it, then and you've received it and you're fine, then I guess it's going to be okay. So it helps to build a little bit of trust. And then of course we go through all of the indications of it, what they can expect. Each person, of course, their immune system is very different, but some of the questions are, am I going to be tracked now by the government? That's one of the things. Are you injecting something in me that's going to change my genetic code? And of course we clarify all that information, and I let them know the only tracking that's being done is the lot number that you received and where you received it, the date and time, and all that's logged in the CDC website. And then what to expect after they get it, and it seems to calm them down a bit.
I can go next too.
Go ahead, please.
Yeah, thanks. I'm just excited to talk about it, I suppose. I think what we also need to remember to share with those that are getting the vaccine is that COVID is really unpredictable. If we have learned anything over the past year, is that it doesn't matter if you're healthy and young, it can hit you very differently, or you could be elderly with a lot of comorbidities and really not have an adverse reaction to COVID or even know you have it. So it's just very, very unpredictable. But vaccines are not unpredictable. We know what type of allergic reaction an individual might get by getting a vaccine, and we're prepared to handle that. So I think that that's an important message to share as well, is that COVID is unpredictable, why vaccine safety is really not.
Yeah, fantastic points. And I can only imagine the types of questions that are coming and coming to the surface when the individuals are soon to receive the vaccination. And Katie, those are extremely good points, about the predictability of it. So one area of confusion has been, why 2 vaccines? If they get the flu shot, it's 1. Why is it 2 with this? How long does it take to be effective? So
I can go with that. So it takes the body about 10 to 12 days after receiving the vaccine to actually build up the antibodies against the virus. And then getting a second dose is almost like a booster. You know, when we were kids, we had all of our frontline immunizations, and then we got a booster shot. So that gives, you know, the body an extra dose, if you will, to build up more antibodies against it. And so they say that after getting the first dose, 10 to 12 days later, you're about 50% immune to getting COVID. You have that amount of antibodies to be able to protect you. But the second dose helps you to build additional antibodies, and it brings you up to about 95% immunity. And I think this is really important point, because when the vaccines were first being given out, there were, I think in California, a nurse actually obtained COVID after getting their first vaccine, and some places were trying to relate getting the vaccine gave them COVID. Well, that's a myth. You can't get COVID from the vaccine. The vaccine is not a live virus. And so, but it just goes to show you they either were exposed to COVID prior to getting the vaccine, or could have been exposed to COVID after getting the first dose, because they're only 50% immune. And that is almost 12 days after. And I think too, that learning that and understanding why you need these two doses to reach that 95% immunity also helps people to understand why you still need to wear your mask, you still need to social distance, you still need to wash your hands. And this is probably going to be around for a while, where we have to still wear our mask, social distance, until we reach the herd immunity.
Yeah, really good point. Kristen, from your lens, what are some of the side effects you've heard about from the vaccination?
Honestly, the biggest side effect that I've heard from family members or friends that have gotten it is that their arm hurts really bad. That's the biggest, the most overwhelming. That's the trend that I've found. Moderna has fewer side effects than Pfizer does. Pfizer, the side effects that are being found are fever, headache, and extreme fatigue. With Moderna, it's they do still have headache. They do still have some body aches as well. But again, these are the side effects that we're seeing are really just our immune system and our response to what's being put in our body. So you think about it, whenever you get sick, you get body aches, you get tired, you run a fever. So that's actually just your body's way of attacking the virus and fighting against it. So if you get these things, you're going to feel bad, but you know that your immune system's starting to kick in and it's starting to work. I do know that they're tracking all these side effects. There's a website that you have to put all this information into, because they want to be able to provide as much data, and they're going to continue to study both of these vaccines just to make sure they have all of the side effects covered.
Yeah, really good points. I've been hearing rumors of a third vaccination perhaps being soon approved. Do any of you know anything about that, or is that still a ways off?
So currently, Johnson & Johnson is supposed to be submitting their EUA to the FDA. So EUA is emergency use authorization. So they take the data that they have from the current clinical trials, and FDA looks at it. They are going to hold an emergency meeting. This is the same process that Pfizer and Moderna held in December. So this is expected to happen in February. There is also a fourth one on the horizon that was supposed to be hitting at the same time, but they didn't have enough people in their study to provide enough data to reach that EUA and be able to provide that information to the FDA. So that one is a little further out now.
Very, very interesting. Hopefully that'll speed the rollout out a little bit more. Jill, you mentioned something about herd immunity. You want to talk a little bit more about that, and maybe is there a magic number we should be aiming for?
I think I'll actually defer this to Kristen, just because, her epidemiology background. Absolutely. She could probably speak to it a little bit more. But before I pass it on to Kristen, I just wanted to add something that off of what she said. about the app that's available after you get the vaccine. I think this is really important because it's optional of whether or not you want to register for it, but it's called VSafe. V as in Victor, safe, and it's monitored by the CDC, and you sign up for it, and they send you a text or an email if you don't have via text, and they send you a text and check in with you daily. And so they check daily for the first week, and then it's like once a week thereafter. And you can report any signs or symptoms that you're having if you have to take off work because you've had a significant immune response, and or if you need to go see your primary care physician. I think this is really good. The more people that sign up for it that get the vaccine, the more data that we will have as clinicians, and we'll be able to pay that forward for the next vaccine that rolls out and get better with this. But now I'll pass it to Kristen for the herd immunity.
So when we talk about herd immunity, there's not really necessarily a magic number. I know that right now with COVID, they're aiming at least 70% receive the vaccine and are considered then immune from COVID, to then say that maybe start considering that herd immunity. When we talk about herd immunity, what that does is it means that either people are vaccinated against the disease or that they have had the disease and then are naturally immune to the disease. So if the virus or the bacterial infection is out in the population, if a lot of people are immune to it, and there's some people that are not immune to it because they haven't been vaccinated or they haven't been challenged naturally, they're less likely to get it just because less people have it and less people are carrying it.
Very interesting. And that speaks to the speed of the rollout of it. And Katie, you jump in on this one. Who can give the vaccination? Is it, how broad is the healthcare base that can give the vaccination?
This is another one that depends on the state. So some states are saying students are covered under the umbrella to give the vaccination, while other states are not necessarily including those providers into that network, I guess I should say, on who can and who cannot give the vaccine. So again, it makes it a little bit operationally challenging for healthcare system leaders as well as educational leaders to really know exactly how to use what staff, where, and when to effectively operationalize administering the vaccine.
Sorry, Danica, I just wanted to add to that because that's very, very important. And I think that is why we are seeing a delay in getting the shot into people's arms. If you think about it, nurses are the first people that you would think are going to be administering the vaccine. Well, nurses are on the front line taking care of this COVID spike. And so, they're working very long, hard hours. And so to be able to step away from caring for those patients to give the vaccine is challenging. Here in Hawaii, we do have pharmacists that are approved to give the vaccine, as well as physicians. And I do have to say, like with our local Department of Health, the Kauai Medical Reserve Corps that I volunteer for, we have approximately 5 Department of Health full-time employees that are managing and running the clinic, but we have 25 volunteers. And so me being one of those volunteers as an academician, I don't do that in my normal day-to-day job, but also retired physicians, retired nurses, retired educators. And, because we have so many volunteers, we're able to set up so many clinics. And, I think that having nurses that are retired that could come back in and volunteer for their local Department of Health, calling them up, that can help. Pharmacists, ENTs, and paramedics are also able to give the vaccine, at least here in Hawaii. But, looking up on your individual state Department of Health website and seeing how you can help is only going to help us reach that herd immunity quicker too.
Good feedback. And, the collection of, and I say this term with endearment, of brainiacs on this line. So answer this question in a way that I can understand, but how are vaccinations made? Where is this coming from? What is being injected?
I can speak to it from a very layman's term, but then have Kristen add in, because she's definitely the microbiologist, epidemiologist background. But the way that I explain it, at least to my patients, is, this is a messenger RNA. So it doesn't alter our genetic code. It's, the messenger RNA is literally like little instructions, if you think of it that way. And so you're getting instructions injected into your arm that are going to go to the cells, and they're going to tell your cells, hey, you need to prepare for something that may attack you. So we want you to do this XYZ. So the cells then produce a protein spike, which is what is on the coronavirus, to help to then for our body to produce antibodies against it. But once that protein spike is built, our cells then tear up the instructions because they don't need it anymore, and our body does the work. And so then we have immunity without having a live virus in us. And I'll defer to Kristen to explain it probably a little bit better from a medical technique.
Actually, I think that is a really good way to explain it, especially given that not everybody has a background in virology and microbiology, because I can talk about all kinds of proteins and names of things, and it's not worth it. In the end, all vaccines have something in them that is part of a virus or mimics a piece of a virus. In this case, it's just a piece of mRNA, and that little piece it's put in your system, and then your system it challenges your white blood cells, but it doesn't do it in a way that makes you sick. It just introduces the virus to your white blood cells, so your white blood cells can then understand and make memory cells, make memory antibodies. So the next time that it's challenged naturally or by a wild virus, you've already got those antibodies in those memory cells, so they can come out and they can attack it right off of the bat. So I think it's actually a really good way that you explained how viruses work. The good thing about the mRNA viruses are that a lot of times they don't focus on a particular strand of a virus, because we know that viruses mutate frequently because they're such simple, they're not even organisms, they're just such simple things that they can mutate frequently. But when you have the mRNA vaccines, they usually can help create immunity to a whole family of a virus rather than just by strand, because they focus on being able to protect you against a whole family, which is good if we're talking about we think the virus might mutate in the future.
So let's expand a little bit about those mutations. What do you think will be the impact on those mutations on the vaccination? I know it's already mutated, and the conversations that it's mutated multiple times. When do those mutations become problematic with the vaccination?
They become problematic with the vaccination when the virus alters the way that it's getting into our cells, because currently that's what the vaccine focuses on, is the virus's ability to get into our cells. That's actually how viruses replicate. They can't replicate on surfaces. They can't replicate in your body. A virus has to enter your cell and use your cellular machinery to then create baby viruses, basically. And then the baby viruses get released, and that's how you get sick. So if the virus starts to mutate where it's using a different protein or finding a different way into your cell, that's when the vaccine might not become as effective. However, a lot of times, anytime that you have a vaccine, just like with the flu, anytime that you have a vaccine against any flu strand, it will protect you against the next flu strand.
Good point. And, in talking about the flu, I think, and correct me if I'm wrong, the flu vaccination is it somewhere in the neighborhood of about 70% effective, or is it less than that? What's the magic number there, and how does it compare to the COVID vaccination?
So with flu vaccines, it's a year-to-year thing because the flu vaccines change based on the predominant strands that we actually see in the southern hemisphere, and then we base our manufacturing on what they're seeing. Yes. So sometimes you've got a vaccine that doesn't match the strands that we're seeing wild, but the efficacy of these vaccines can be as low as 40. They can be as high as 60 or 70, but they're rarely over that 60 or 70%. So from a vaccine standpoint, this is the COVID-19 vaccine is a very effective vaccine. It's got a high efficacy rate.
So let's fast forward a year. So we're coming into, we'll say spring of 2022. What do you think the environment will look like? How will things be back to normal, or do you believe that we will still be doing certain behaviors? What will it look like?
I can take the lead on this one. I think that we have a lot of lessons that we learned over the past year and how we deliver healthcare and how we work together even as a society. I do think things are going to open up a bit more. And I think if we stay on the path of encouraging vaccination early while still taking our preventative measures of masking and wearing gloves, we might see what we're seeing in Northeast Ohio, which is a delay of inpatient admissions from regular influenza because we're taking those measures. So this is a good thing because it keeps our capacity at the hospital in a place that we can manage it as healthcare providers, and then won't run into a big issue with hospital bed space, and we'll be able to care for those that become sick, whether it's with COVID, unfortunately, or with regular influenza and pneumonia that we see historically at this time of year. So as that will continue to buy us time to administer the vaccines to more and more people, which will allow for greater connectivity a year from now, which I think we're all hopeful for. But I think that there's certain practices in healthcare delivery, like an expansion of telemedicine, that is here to stay because of COVID, and even more remote work. There's things that we can do remote very well that I think we've adapted to and a lot of us enjoy, but that there's things that we want to see come back. And I think if we can strike that balance, that next year will be far more in a face-to-face capacity than we find ourselves in right now. And I know that all of us on this call likely wish for that to happen, and I think that we're going to get there.
Jill, what will it look like on Kauai?
Well, I'm hoping that it will look like tourism has returned because, you know, being on an island, our economy has taken a huge smash, and we're still there. It is quite different living here with a population of 72,000 and not very many tourists, because when we were in the height of our tourism season, you know, we would have anywhere from 250,000 to 1 million people on the island, just in tourists. So you can imagine, you know, the traffic and whatnot. But I'm hoping that this vaccine is definitely going to bring back that tourism. It will be interesting for all of us. I think there's still a lot of unknowns too, what the future holds, but in terms of travel and, you know, what you need to travel. And, you know, we just saw recently that now anyone coming into the United States from another country are going to have to test negative, you know, have a negative COVID test. I mean, does the future hold that in order to get on a plane, you need to have, you know, your vaccination card? I mean, we don't know. So, but I think that we're still, we're still probably going to be wearing masks, unfortunately. And so, you know, we thought it was short-lived. I think we were all hoping it was going to be short-lived. That I know I was, and that we could get rid of them. But it's interesting how everyone's became so fancy with their new mask now. So a new fashion trend, I guess.
Oh, absolutely. I know many of us have the teenage age children, and it's amazing what goes into mask selection every day. I'll speak for myself. I'm personally hoping that tourism comes back, so I'd like to be in Hawaii. I will wear any mask in Hawaii and be entirely happy. So yeah, thank you for that. Kristen, what do you think it will look like in Ohio?
I actually like what Katie K said. She had a lot of good points. We've learned and adapted a lot. So I know that nobody likes to stay at home and not go out to eat and not go places, but we've learned a lot of good lessons. And so it wasn't all for nothing. We've learned to change the way we do things that actually might be more efficient, even in a non-global pandemic situation. We have been faced with H1N1, Ebola, where there were all these, that we've had these challenges before and never quite got as bad as this. But just because we've gotten through this one, it doesn't mean that there's not another disease that's out there that might cause a similar situation. Emerging infectious diseases are a big concern because as small as the world is right now with global travel and everybody coming into contact with each other, and as much pressure as the human population is putting on the globe, we start to come into contact with animals in areas where we've never been, and that's where the diseases are, and that's where they start. And these are diseases that have never challenged us. They're novel viruses. So I think that if we can remember everything that we learned here and start applying some of these things just all the time, maybe not to the extent that we're doing it now, but if we can just remember this and learn, I think it really prepares us to face any threat better, and then hopefully not have to go back into these massive lockdowns like we have before.
Well, such fabulous points, and I'll speak for myself. I anxiously await my vaccination, and the three of you made it much more comfortable, and thank you for addressing it with your candor and just so directly about the experience and the next steps. With that, I'd like to thank our panelists and all of you for spending time with us today as we explored the world of COVID and the vaccinations. Please join our mastermind next week as we discuss the opioid epidemic and healthcare. And with that, again, thank you to the three of you for your time, and I wish everyone to be well. Thank you.
Thank you.